Good afternoon, and I was given this topic of Men's Health Update 2018, and I figured that I'll give some updates on PSA screening, erectile dysfunction, and I was asked to emphasize on hypogonadism and such issues. So PSA screening guidelines in 2018. Very hotly debated. USPTF several years ago came back and gave PSA a fail grade, saying it doesn't save any lives, unnecessary biopsies, not helpful. What happened over the last 7 years was less people started getting PSAs. We started seeing an increase in people with metastatic prostate cancer. The USPTF went back, revised their guidelines. The new guidelines that the AUA, which is the American Urology Association, came up with are as follows. So men between age 40 and 54 who have a family history of prostate cancer, who are African American, or they have a family history of prostate, pancreatic, ovarian, or breast cancer, need to be screened for prostate cancer, need to get a PSA test. 55 to 69, it's a shared decision making between patients and their physicians, and that's what I always tell all my patients when I see them. We can do a PSA test on you. It is the only blood test that's available as a screening tool for cancer diagnosis. It is very sensitive, but not specific. 1 in 3 men with a positive PSA will end up having prostate cancer. So if you're willing to go ahead, we can do a PSA, and then we can figure out what the PSA shows and whether we need additional tests before we do a biopsy to detect prostate cancer. Age 70 and above, it's not recommended in men with a life expectancy of less than 10 years. 10 years is a number picked by most people, saying if you have a life expectancy of less than 10 years, it's unlikely that prostate cancer would kill you. We see now in our practice, and I'm sure you guys do, guys in the 80s, 90s, healthy, walking around. So if I see somebody who's 75 and in good health, I offer screening. I don't say, let's screen you for prostate cancer, because that guy could be back at your office at 85 with metastatic disease and say, you never offered me a PSA screen. So if you don't do a PSA, I would at least record it in your record saying discussed with the patient denied and does not want a PSA test. So what is the PSA range? There's different ranges. The easiest one to remember is 0 to 4, but that oversimplifies PSA. Typically what we use is men under age 60, 2.5 is the upper limit of normal. And then if they're less than 4 over the age 60, you're good with that. The other thing to remember is PSA velocity. Anytime your PSA goes up more than 3/4 of a point in a calendar year, you need to refer them to a urologist, or you need to say, there's something going on, maybe we do another PSA in 6 months and make sure it does not continue to go up. Erectile dysfunction. Again, men who present with erectile dysfunction, they need to have a very thorough medical exam, sexual exam, and a psychosexual history, selective lab testing. And what I do on men with erectile dysfunction is I will get a serum testosterone level on them just to be sure that they're not hypogonadal. They're validated questionnaires, and I get the questionnaire on every patient I see with erectile dysfunction because it's very good to compare them, saying, as people come in, men come in, they say, oh, it's horrible. I say, well, do this questionnaire. Oh, the questionnaire is a little better than last time. Why did that happen? So I think getting a questionnaire is good. And I know in the primary care office you have so many things to look at, and it's sometimes not practical to do a questionnaire for everything. But keep that in mind. There's a SHIM score that's available, and that's a very good screening tool. Men should be counseled that erectile dysfunction is a risk marker for underlying cardiovascular disease. Several studies have shown that when they present with erectile dysfunction, typically within 5 years they will have some kind of coronary event. Or let's look at it in a different way. If they come in with a heart attack or some kind of cardiac event, if you look back at their history in the last 5 to 7 years, they had erectile dysfunction. So I think it's a good marker to keep that in mind as well. So what are the treatments for erectile dysfunction? Lifestyle modification, and I'm sure each and every one here will tell you that's the hardest thing we can get out of our patients. Go start working out, lose weight, eat healthy. Easier said than done. PDE5 inhibitors, and they've been around now Viagra has been around for 20 years now. So there's Viagra, Levitra, Cialis. Again, they all work well in the right patient. Big problem is the cost. They're considerably expensive, although now Viagra is generic and Cialis reportedly should be generic next year, but they are still significantly high in price. Men with erectile dysfunction and hypogonadism, so if they have both, so if you see somebody with erectile dysfunction, you get a testosterone level, it's low. Until and unless you get their testosterone level up to normal, you have to fix the hypogonadism for the PDE5 inhibitors to work well. If you don't fix that, they are not as efficacious as they would have been with testosterone replacement. Vacuum erection devices, again, these are available, they are hard to use, patient satisfaction is very poor. Injection therapy, that's what you hear on the radio. Anytime you turn the radio on now, when you say 25 again, Louisville Men's Clinic, they're all injection therapy clinics. They will bring you in, give you an injection, and then they say, okay, now put $2,500 down and you can get as many injections as you want for the rest of the year. So that's what the men's clinic does, is injection therapy. Transurethral prostaglandins, I rarely use those, very expensive, they don't work as well. They're for the guys who say, I don't want an injection, it's transurethral, it works not as well as injections. Penile implantation, again, when you fail all those other things and you're in reasonably good health, we can put penile implants in, and they seem to work really well. Low intensity shock wave therapy, I'm sure this is another thing you will see in the newspaper and the radio now, is shock wave therapy for erectile dysfunction. What is that? We've done shock wave therapy for stones for years and years. There's new data now that says that if you do low intensity shock wave therapy to the penile arteries, you can improve flow, and that helps with erectile dysfunction. It's investigational, it's not FDA approved. So what is testosterone? It is the most important androgen that is important androgen produced by the testes. It plays an integral role in men's health. It acts on several sites, acts on the brain, acts on the peripheral nerves, acts on the corpora cavernosa. And like I said, without adequate testosterone, you will not get good results from the PDE5 inhibitors. Androgen deficiency may be associated with decreased libido and insensitivity to PDE5s. So what is primary? Primary is where the testicles themselves fail. Where do we see it? Klinefelter syndrome, undescended testes, mumps, and all these other things which we rarely see. Late onset hypogonadism, I like to call it menopause, like menopause. It's when testosterone levels drop with age, and that's when we see it most often. Secondary, so it's pituitary and hypothalamic disease, not as uncommon as we think, so we need to kind of keep our eyes out for it. If somebody's had brain surgery, radiation, trauma, tumors, I will probably pick up 3 or 4 pituitary micro or macro adenomas a year in younger patients with low testosterone. So what are the symptoms? Fatigue, sleepiness, erectile dysfunction. In depression, there's a higher incidence of low testosterone, weight gain, gynecomastia. And now the awareness is so high because all these people continue to advertise everywhere talking about, do you feel tired? Do you want to feel like you're 25 again? Do you want to feel like you want to do this and that? And all of us will say, I wish I could feel like I was 25 again. But truth be told, we won't be. But I think that's the attraction of trying to get you back to what you used to be. So what do we do on a physical exam? There's a targeted physical exam, testicular volume, make sure that they don't have testicular atrophy. Gynecomastia, again, we see that fairly often. Obese men, that is men over a BMI over 30 or a circumference of the waist more than 40 inches should have testosterone levels checked no matter what. Obese men are 5 times as likely to have low testosterone than men who are not obese. So anytime you see somebody obese, other than, in addition to all the other tests you're going to order for them, order a testosterone. So a diagnosis of low testosterone should be made after 2 early morning testosterone levels. So testosterone, like other hormones, has a circadian rhythm. So it peaks in the morning, so 8 a.m. is typically the peak. So get a testosterone level, 2 separate testosterone levels at 8 a.m. or sometime in the morning will make the diagnosis of hypogonadism or low testosterone. So again, the question is, somebody comes into your office with testosterone of 260, are you going to treat them? I mean, for me, what is most important is not the lab value. Do you have the symptoms? Do you have the signs of hypogonadism? I don't want to treat a testosterone level of 250 or 270 because we'll see that testosterone is very finicky when you measure it in the lab. Sometimes it's 250. You turn around 3 weeks later, it may be 320. So are you going to treat the guy with 250 and not the guy with 320? So that's why I always do a good history and see if they have any of the symptoms. Again, like in obese men, consider checking testosterone level in men with unexplained anemia, bone density loss, diabetes, who are patients with chemotherapy, HIV/AIDS, and chronic narcotic use. And we see this quite often now in patients who are on chronic narcotics, that they have significantly suppressed pituitary hypothalamic axis and they have low testosterone levels. So that's fairly often we see that. Chronic steroid use also does that. In patients with low testosterone levels, I'll always get an LH and a prolactin level just to make sure that the axis is working well. In men who have persistently elevated prolactin levels, they need to go see an endocrinologist. Oftentimes I'll order an MRI of the brain just to make sure they don't have a pituitary microadenoma or a macroadenoma. Diabetic men who have significantly lower testosterone levels than men who are not diabetic. So that's the other thing is when you're diabetic, make sure you do a testosterone level on them. And all men with type 2 diabetes need to have their testosterone levels checked. So how is testosterone circulating in the blood? So about 50% is loosely bound to albumin. About 44% is bound tightly to SHBG or sex hormone binding globulin, 4% to the corticotrophic binding globulin, and 2% circulates free. So that's the whole thing about free testosterone, total testosterone. What is more accurate? Free testosterone is the one that actually is the testosterone that we function off. Bound testosterone really doesn't matter. Hard to measure the free testosterone. So what we do, and so the way to measure total testosterone is a radioimmunoassay or an ELISA study. They're rapid tests, but they have high variability. The better way to test the free testosterone is equilibrium dialysis, which is very labor intensive. The best way to do is a calculation method. You do what's called, you get the albumin level, you get the testosterone level, and you get the SHBG and do what's called bioavailable testosterone. So that's testosterone that's bound to albumin and circulating free. So things that make SHBG go up and go down, and I've listed them here. Clinically, does that really matter? And I've really not seen anything that helps me with treating somebody based on their SHBG. There's not much I can do to push the SHBG up or down. Estradiol is measured in men who have gynecomastia. So if you have gynecomastia, check an estradiol level. And sometimes when we are doing testosterone therapy, we will put them in an aromatase inhibitor to reduce conversion of testosterone to estrogen, especially if they have gynecomastia. I always get a baseline PSA in men over 40 on testosterone therapy. So in men where testosterone levels are less than 150 and they have a low LH or luteinizing hormone level, they need a pituitary MRI to rule out a non-secretory adenoma of the pituitary. Prior to starting testosterone therapy, and you guys do it on all patients, but I have to remind myself to get a CBC, a CMP, a PSA before I start the testosterone to have a good baseline. And then once they hit steady state, every 6 months you repeat the CBC, CMP, PSA, and testosterone just to make sure that everything is staying stable. Polycythemia, #1 adverse event after testosterone therapy. So you see patients back, hemoglobin is 16, 17, next time they're back to 18, 19, and that's when you need to put the brakes on and say, stop, we need to get away from the testosterone, send you to hematology, or go donate blood. We need to bring that RBC count, hemoglobin, and hematocrit down. In men who are interested in fertility, and this is one of my other pet peeves about all these 25 again like clinics. Men who are 25, 30, we go there and say, I have all these symptoms. They'll say, sure, we'll start you on testosterone. They go on testosterone, then they come back to see me and say, we've been trying to get pregnant for the last 2 years and nothing is happening. Well, guess what? your spermatogenesis is down to nothing because you have exogenous testosterone, you don't make any testosterone intratesticular, and you're having azoospermia or low sperm count. And sometimes in these guys, it takes a few years for that axis to reestablish, and they're wasted all this time. So anybody who is in the age group of saying, I think I may want to get pregnant, we may want to have kids, do not ever write testosterone for them. So how do you treat low testosterone? So here are some numbers. Testosterone testing and prescriptions have tripled in the recent years. About half the men I see in my office under the age 45 have tried testosterone without any prescriptions. Where'd you get it? Well, my trainer in the gym gave it to me. Somebody gave it to me. I tried it a few times. It worked. Can I get some? Okay. So 25% of men who receive testosterone therapy do not have their testosterone levels checked before initiating treatment. They'll just say, I feel kind of tired, and my friend had testosterone, so I took a couple of shots and I felt great. Of the men who are treated with testosterone, nearly half of them don't get their testosterone checked after therapy commences. So that's horrible. Somebody has low testosterone, you put them on testosterone, you just don't know where their testosterone is, and they just go willy-nilly get testosterone injections or whatever else, and you have no idea where they are. The goal is to raise testosterone between 450 and 600. This is the other thing I have, is when you look at labs on testosterone, they say normal is between 300 and 800. So how do you tell somebody who's 290 saying you're low, but 310 you say you're in the normal range? So that's kind of one of those things. When you get there, I will always get a free testosterone level, and I'll say, yes, your free testosterone is low. We can supplement you with testosterone. But the goal is to get it between 450 and 600, and I think most people at that range feel fine. Oral testosterone is not administered because of the liver toxicity. So people do use and abuse oral testosterone with all these testosterone supplements, but you can get over the counter, but beware, you cannot do oral testosterone. Injectable is the most commonly used testosterone replacement modality because it happens to be the cheapest. Then there are testosterone gels, and then there's the testosterone underarm application. So here's a really, really busy slide, but it goes through all the different available testosterone topical treatments. So there's Testim, which comes in tubes. It's 50 milligrams per tube. You can use 1 to 2 tubes, and in 4 weeks, remeasure a testosterone. Then there's Androgel, and comes in 1%, 1.62%, same thing. Fortesta comes in a pump, 4 pumps, and that's 40 milligrams, and you put it on the thigh. Axiron goes in the axilla or underarm, and then there are androderm patches. A couple ones that I've never used, but they're around. One is a buccal system called Striant, and you have to put this thing inside your mouth twice a day. I don't know who would remember to put this little patch in their mouths twice a day. I've offered it to patients, and nobody really has been interested. And then this is the other one, is the intranasal. You got to 2 pumps every 8 hours, so you got to carry this little thing in your pocket, and every 8 hours just snort it. I mean, I don't know that I have ever used it. So testosterone, cypionate, and enanthate. So they're both injectable depot testosterons. They both work well. Cypionate is the most commonly used testosterone depot formulation in the United States. In Europe, enanthate is the most commonly used. There's a slight difference in the molecular structure of both these, but typically they're both very similar. So the starting dose is 100 milligrams. Sometimes people get started on 200 milligrams every 7 to 14 days. After cycle 4, get a testosterone level, see where they are, and then you can adjust. Then there's Avid, which I don't know if anybody here has used. It's about 750 milligrams. You do it at day 0, week 4, and every 10 weeks. Again, not something I've used because you have to give the injection and have them wait for about 2 hours in your office. There's a small incidence of anaphylactic reaction and coughing and some of these other things which I have stayed away from. And then there's Testopella, testosterone pellets, and you put 10 to 12 pellets subcutaneous every 3 to 4 months. It works well. We do it in our office, and patients are happy because they don't have to get a shot every 10 days or 2 weeks. They don't have to put a gel on. Once we reach steady state, we know how often they need it, And so you get a testosterone level in 2 weeks to see where the peak is, and then again at 12 weeks to see where they kind of nadir, and then you can kind of come up with a good idea as to how often and how many pellets they need. So when men are hypogonadal and treated with testosterone, what do they feel? Their sexual function gets better, erectile function gets better, they generally feel better, responsiveness to PDE5s increases, improved exercise tolerance, all-cause mortality improves, and metabolic markers, especially markers you see with type 2 diabetes, improve. So clinicians need to inform patients that low testosterone is a risk factor for cardiovascular disease. So you need to supplement their testosterone, bring it up to normal. There was a paper in JAMA, I think 3 or 4 years ago, talked about the correlation between testosterone therapy and cardiovascular disease and heart attacks especially. And it created a big controversy, and since then there have been about 4 or 5 papers that have come out saying there is no link. So at this point in time, I tell my patients saying, if you're hypogonadal truly and have all the signs and symptoms of low testosterone, I don't mind supplementing your testosterone. Will bring it up to normal, and the risk of cardiovascular events or heart disease or stroke or heart attack from that it's really not, it does not increase the risk, but I think that's still being studied. There's no definite evidence between testosterone therapy and blood clots. Again, the other question is there any evidence that links testosterone therapy and prostate cancer? The answer is no. On the other hand, if someone has had prostate cancer, you need to be careful prescribing testosterone to them. Most urologic literature says you can wait for 2 or 3 years and you can start them on testosterone, and I wait for 2 years, and if their PSA is low or if they've had a prostatectomy and the PSA is 0, I start them 2 years out from their primary treatment and monitor their PSA closely. So what you do is follow up when you start them on a testosterone gel, injection, or whatever. I see them back in 6 weeks with a testosterone level, repeat labs, like I said, every 6 months. So here's the trick. I see the patients back in the office in 6 weeks, and I say, Mr. Jones, how's the testosterone working? The first question is, what's my number? I said, oh no, I don't want to talk about your number. Tell me how you feel. You'll be surprised, somebody with a testosterone of 800 will tell you, I still feel very tired. I just feel my sex drive is low. I feel terrible. Can you go up on my testosterone? Then I say, guess what? Your testosterone is supranormal. It's 820. So it's testosterone is not your problem, so let's take your testosterone away. So I never, because these guys, a lot of them are used to going to these clinics where they'll give them as much testosterone as they want, and they bring their levels to 1,200 or 1,500, and then if you're sitting at 400 and you go to 1,200, you're going to feel like Superman. But guess what? You take it away, you're going to feel like your testosterone's down to 100, and then it's just a big fall. So I'm always careful about not overdosing them or trying to go by what they feel. I just see what their numbers are. So when you're using gels or creams, I talk about transference. There's a lot made about it, but I don't think it's that big a deal. As long as you don't put the testosterone gel on and then go rub it on your kids or are very intimate with your partner, it's not a big deal. You put it on, let it dry, put a shirt on, there's no transference. So it's not something that we need to worry about that much. Lifestyle modifications, I tell everybody, but very few people do that. Now, if you're in the age group where you're looking to have kids, we said testosterone supplementation will reduce your fertility and your spermatogenesis. So how do you fix that? So you can put them on something like Clomid or aromatase inhibitors that'll help restart the axis, the hypothalamic pituitary axis, and stimulate the testicle to make its own testosterone and help with spermatogenesis and help with improved testosterone levels. So take-home points, it's common in older, obese, and diabetic men. It's easy to diagnose and treat. There are several options and modalities to treat patients. The goal is between 450 and 600. Treat the symptoms and not just the lab values. Monitor for polycythemia and liver dysfunction. Again, liver dysfunction is very rare with gels and creams. You see some liver dysfunction rarely with injections. If they are difficult patients, you can refer them to urology or endocrine. And the goal for this talk for me was, I think several of our patients are seeing all these people on the outside, and we've read in the newspaper, we have seen, and I've seen a lot of people who have moved away from those clinics to see me in the office, that they practice bad medicine. And I think we just need to make sure that people are not taken advantage of, and they get good treatment. And I know everybody here will do the right thing and do a good job, but I think their goal and their motivation is completely different from what's best for the patient. They're just trying to do what's best for themselves. So I'll take any questions. I'm done 5 minutes ahead of time, so you get a bigger break. Yes? Well, I do PSA because if they have prostate cancer, if they're developing prostate cancer, then testosterone is a very strong growth factor for that. So that's just to make sure that they are not getting prostate cancer and we're not fueling the fire. So that's why you get regular PSAs. Yes? I'm sorry, I didn't hear you well. Actually, you will see a fairly good results. I mean, I can't tell you exactly what percentage you see improvement in, but if you lose your abdominal fat, which is where you have aromatase, that converts testosterone to estrogen. So if you see obese men, they also have breast tissue. So if they lose weight, especially abdominal fat, that conversion of testosterone to estrogen goes away, and so their total testosterone goes up. So if you are really motivated and focused, lose weight, you will see an improvement in your testosterone level. Do you see a decrease in? Yes. 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 We still do digital rectal exams annually, yes. Because 90% of the prostate cancers are diagnosed by PSAs. There's still 10% cancers where you have an abnormal digital rectal exam, or the prostate cancer is so de-differentiated or not the normal adenocarcinoma that you can have a nodular prostate. So yes, the urologists still recommend prostate exams, yes. Thank you.